Good morning, everyone. Let me present my 6-month progress on my PhD topic, which is investigating different etiologic factors of preterm birth. I'm Eszter Hoffmann, and I work as a resident doctor in the Department of Obstetrics and Gynecology in Semmelweis University. My vision is to contribute to the prevention of preterm birth, and my mission is to improving the protocol for the treatment and prevention of vaginal infection during pregnancy. I have 3 ongoing projects. The first is investigating the efficacy of regular screening of vaginal flora during pregnancy to reduce the rate of preterm birth and premature rupture of membranes. The second one is investigating the efficacy of treatment of abnormal vaginal flora during pregnancy to reduce the rate of preterm birth and premature rupture of membranes. And the third one is a genomic study, which title is Genetic Variation Associated with Preterm Birth. Now let me talk about my first project. Its title is Investigating the Efficacy of Regular Screening of Vaginal Flora During Pregnancy to Reduce the Rate of Preterm Birth and Premature Rupture of Membranes. The background of this topic is that the incidence of preterm birth is between 5 and 18% worldwide, and it's 7.5% in Hungary. We spend almost 8 billion forints for the hospital care of the neonates in the first 6 months. On the left side, you can see a figure that we use in our clinic to explain to the patients that as the number of the weeks of the pregnancy decreases, the risk of the complications and mortality gets higher and higher. There are different etiologic factors behind preterm birth, and a common cause is infection and inflammation. And there is no protocol for screening of vaginal infection during pregnancy care, and our aim is to see if routine screening of vaginal infection could prevent preterm birth. Here you can see the details of our study, and our hypothesis is that regular screening of vaginal flora can reduce the rate of preterm birth. We did the systematic search on the 21st of October, and we found 13 eligible articles. And now I would like to talk about our results. Our first outcome is preterm delivery before 37 weeks. Here you can see that we have subgroups by the type of the screening methods. And here you can see that we have an overall result, which is 0.71. This means that screening of vaginal flora compared to no screening can reduce the rate of preterm reduce the odds of preterm birth by 29%, and this means that we can avoid 29 preterm deliveries out of 100. We did subgroup analysis by study type, and here you can see that the RCTs didn't have significant results, but this data still suggests that screening of vaginal flora can be beneficial in the prevention of preterm birth. We have an outcome for preterm delivery before 32 weeks, and as I mentioned before, as the number of the weeks of pregnancy decreases, the chance and the risk of the complications and mortality gets higher and higher. So that's why it's very important to avoid these preterm deliveries. And here you can see that the overall result is 0.55, which means that we can avoid almost the half of the preterm deliveries before 32 weeks. We have an outcome for low birth weight, and here you can see that the birth weight of the neonates under 2.5 kilograms means that we have low birth weight. And here you can see that the overall result is 0.64, which means that we can reduce the rate of the number of the low birth weight neonates with 36%, and this means that we can avoid 36 low birth weight deliveries out of 100. We did subgroup analysis by study type, and here you can see that the result for the RCTs is significant, so this data strongly suggests that we should use the screening of vaginal flora during the routine pregnancy care. And we have a result for birth weight under 1 kilogram, which means that these neonates born before the 28th week of the gestation, and they have the highest risk for the complications and mortality, and that's why it's very important to avoid these deliveries. And here you can see that we have an overall result which is 0.33, and this means that we can reduce the rate of these deliveries by 67%. We had more outcomes, but I wanted to talk about these 4 ones because these are the most relevant. And as a summary, I would like to talk about the strengths and the limitations of our study. The strengths are the high number of the patient, the different type of screening methods were examined, and easily executable screening methods were included. The limitations are the low number of RCTs, different type of the treatment protocols, and the pregnancy care protocol is different in each country, and probably this can be behind of the high heterogeneity. As a conclusion, I would like to say that routine screening of vaginal flora has beneficial effect in the prevention of preterm births, and we found the strongest significance in studies where screening was performed by healthcare specialists, and the most effective method seems to be the gram staining compared to pH screening and pH staff screening. As a summary, the implication for practice is that routine screening of vaginal flora is recommended during pregnancy care, and it's strongly recommended in high-risk population. And implication for research is that further RCTs are needed in pH screening and in gram screening as well, and the screening methods should be compared to each other. Now let me talk about my second project, which is investigating the efficacy of treatment of abnormal vaginal flora during pregnancy to reduce the rate of preterm births and premature rupture of membranes. The background of this topic is that a common cause of preterm birth is infection, and there is no guideline for managing vaginal infection during the pregnancy care. And when we talk about treatment, we can choose oral or local treatment. We can choose antibiotics like clindamycin or metronidazole. We can choose clotrimazole. We can choose lactic acid, probiotics, or we can say that we don't treat at all. And our aim is to see if the treatment of abnormal vaginal flora could prevent preterm births. Our clinical question is that can treatment of abnormal vaginal flora during pregnancy reduce the rate of preterm births and premature rupture of membranes, and which is the best treatment? Our population is pregnant women, intervention is treatment, any kind of treatment, comparison is no treatment, and the outcomes are preterm births, premature rupture of membranes, and the risk factors of preterm births. And our hypothesis is that treatment of abnormal vaginal flora can reduce the rate of preterm births. The clinical implication is that decreasing the rate of preterm births by updating protocols for the treatment of abnormal vaginal flora. We did the systematic search on the 21st of October, and now we are in the phase of checking the full text for the meta-analysis. And now let me talk about my third project in a nutshell. Its title is Genetic Variation Associated with Preterm Births, and it's going to be a genomic study. The background of this topic is that the etiology of preterm birth is variable, and both maternal and fetal genomes likely affect susceptibility, and different genes can be associated with preterm birth, but more examinations are needed according to the literature. So that's why we would like to do examination on placentas that were collected from pregnancies with IUGR, preterm birth, and from a control group. And we are planning to do the examination of inflammation and preterm birth associated genes like MBL2 and DFB1. And our aim is to identify fetal genetic variants that predispose infants to preterm birth. And as a summary, I would like to say that we would like to submit our first 2 projects by May in 2022, and we would like to submit our third project in the first part of 2023. And to close my presentation, I would like to share a quote from my favorite basketball player who said, "Everything negative, pressure or challenges is all an opportunity for me to rise." Thank you for your attention.
Well, just that you had actually these two different methods. One is the gram staining and another one is the pH. So is the differences, so I would say that the sensitivity is coming from really from the lousiness of the method of the pH, or it is just not performed well? Or maybe a combination of the two could be better.
Thank you for the question. we were seeing that gram staining, which is a method that was performed by a doctor, was very convincing, and the results were convincing. And when the pH screening was performed by a doctor, it was very convincing and as well. But in the case when we had pH self-screening, so in those studies, the patients got the pH stick, and they did the screening for themselves. That has no effect on the rate of preterm birth. So probably the gram staining and the pH screening, when a doctor does it, it's good and it's effective, but when we have a self-screening, it's not. And I think the gram staining has better results because it's reliable, more reliable test, but the pH screening is easily executable.